consumption is down. For those of you that have been watching the alcohol, because no one drinks alcohol anymore. So maybe we'll see a massive reduction in because I know there's alcohol-induced neuropathy too, isn't there, Dr. Bell?
Correct.
So, anyways, we'll be diving into that. So, Dr. Bell is going to go for however long he wants to, and then we'll open up for a Q&A. So, if you guys want to use the chat or Q&A function, go ahead and layer your questions in there, and we'll go over them at the end. I know that's everyone's favorite part. We'll try to get to everything. But with no further ado, thanks, Dr. Bell, for everything you've done throughout this chapter series. And I know it's going to be another awesome one. So, thanks again for your
Absolutely. Thanks for that very nice introduction. For everyone attending, appreciate you being on. And hopefully this can be a worthwhile webinar for all of you. It's probably or arguably the most common topic that I do talk about when I do my peer-to-peers, mostly because of pure volume. Like Beeman had said, and right before I came on, I just did a quick Google search. It's estimated between 35 and 50 million people have diabetes in America. It's pretty incredible. You could fill up, Pennsylvania, New Jersey, Michigan, Ohio, and name a couple other states. You probably don't even have 50 million people. So it's an area of medicine that I'm not going to say it's been underaddressed, but we've been limited in our ability to address it until recently, which is really cool. So for me, and I always start my calls off when I have a call about neuropathy. I guess it's the nerd in me. I do truly find it an exciting topic because we're finally able to help a lot of people with a pretty significant condition that historically has not been very treatable. So it's really cool, and its applicability to us in podiatry. Most of my calls on this topic are podiatrists, but I'll speak to some family docs. I'll speak to some pain management docs. We'll see neuropathy. And of the about 50 million, and this data would align with what I see in the 20 plus years I've been practicing, about 3/4 of all diabetics will develop neuropathy. And that's why we're talking about this topic tonight, because it presents to our offices so often. And our weapons were, like I said, were limited. Like all of you out there know, the weapons were limited. And for a lot of docs, as they're entering the field of biologics, they're pretty excited about learning more about the topic to help their patients in theory, and then of course then ultimately in practicality, way much more than they were before. So a quick, little background with the mechanisms of action as to how neuropathy takes place. I don't want this to be a lecture in anatomy or physiology too much, but I think a little chat about it is worthwhile. And I'll refer mostly during the talk about diabetes-induced neuropathy because that's the most common underlying condition that caused it. And we know there's multiple others. Beav mentioned one, alcohol-induced. I see in my practice a fair amount of chemo-induced. Here and there, you'll see it secondary to hypothyroidism. I'll see it secondary sometimes to types of anemia. But far and away, the most voluminous patient that presents to the office with neuropathy is a diabetic. So the reason I want to mention the kind of the physiology behind it is because it really ultimately applies to how I like to attack it. So diabetes, of course, means high blood sugar, high glucose. And there are certain parts of the anatomy that do not need insulin to absorb the glucose. So insulin in most parts of the body is very necessary, of course, to carry the glucose into the cell for its uses. But the small nerves, the feet, the arteries, the kidney, the eyes, probably about it, don't need insulin. So therefore, that part of the anatomy is flooded with glucose. And when there's too much glucose in a cell, there's a breakdown. It's the aldose reductase pathway. It breaks down glucose to sorbitol. Sorbitol is an alcohol. So ultimately, these cells, whether it's a nerve cell or an artery, or like I said before, the kidney, the eye, and then you see that's the parts of the body that diabetics suffer the most in. That's why if you go to any, say, for example, dialysis center, 80–90% of the people sitting there are more than likely diabetics with kidney disease. So anyways, those organs take up all this glucose. The aldose reductase pathway turns the glucose into sorbitol. Sorbitol is an alcohol. And an alcohol, what does it do? Like it does to us overall. What do we feel the next day if we drink a lot of alcohol? We feel very dehydrated. So in the nerve cell, as it becomes dehydrated with absorbent amount of sorbitol in it, it starts to fall apart. And when the nerve cell starts to fall apart, you develop what's called neuropraxia. So neuropathy is the disease, neuropraxia is the symptomatic condition. So what is neuropraxia? It's essentially becomes what allows for the paresthesias to occur. So cell wall falls apart, the nerve cell wall falls apart. And I drew this little, well, I didn't draw it, some of my staff drew it. Probably the whole key here is the epineurium. The epineurium is the outer layer of the cell wall, and that's what kind of starts to fall apart and disintegrate by dehydration with excessive sorbitol uptake into this nerve cell. So when the epineurium falls apart, the axon is ultimately affected. The axon is what conducts the nerve. So it's no different than an electrical wire where a current travels down the current. Well, if there's disruption to the fibers in the wire, say, a light bulb would flicker because there's interference with the conduction. Well, in the axon and the sheath around the axon, the myelin sheath, which I believe I have on this picture, yeah. So the myelin sheath surrounds the axon. The axon is the end of the nerve cell. It's when we talk about axons, we're kind of talking about in our world, we're talking about in sensory nerves, what lies at the very junction of the epidermis and the dermis, what allows for us to have sensation. And it's pretty much the terminal part of the nerve. And when the myelin sheath, which is supported by the Schwann cell, the myelin sheath, it needs something to hold on to. And in the myelin sheath is the key to conduction. And it's the epineurium that starts to fall apart or collapse from too much sorbitol into the cell. So your epineurium falls apart, the axon has nothing to hold on to, the cell kind of falls apart, and then you get altered conduction. And that's what causes all the symptoms: the burning, the tingling, the pins, needles, the numbness. There are two different types of fibers. It's mostly the A delta fibers that are myelinated that are mostly affected. There's also C unmyelinated fibers. They're not as impacted by this whole process, but it's the A delta fibers that are really being affected by this, and nerve conduction just can't take place. And like I said, the myelin needs structure, it needs a scaffold to hold on to. And when it loses that scaffold, it doesn't work properly and the conduction gets interfered with. So the whole problem with diabetes is that altered blood sugar. That's why we're talking about our patients lowering their blood sugar. But when nerves are damaged, that's it. They're damaged, and they don't have a very good inherent way to regenerate themselves. And that's why we've seen neuropathy be such a stubborn condition. I have diabetics that will tell me, Dr. Bell, my A1C is only 6.5 in the last year and a half, and my neuropathy has not improved. And I tell them that the damage has been done, and there's really no inherent way to restructure that nerve cell. So if they function at a 7.9 or an 8.5 for the last bunch of years, and they brought their A1C down with better sugar control, diet, and exercise, they're not necessarily by any means going to see that connection reoccur because they're gone. And the body doesn't build them back up. And that's the problem with neuropathy, and that's why it's so chronic. Historically, we didn't really have much to do for our patients. We mostly, throughout easily the first 2/3 of my practice, I'm sure for all of you out there practicing 20 years, you can relate to this. Some newer practitioners have better, newer options. We basically just put people on medication, and gabapentin and Lyrica have been the two most popular. And we do what we have to do as doctors. We want to help our patients, but as we all know, gabapentin or Lyrica, they're not helping the problem whatsoever. They're masking the symptoms for the life of the drug, which is essentially about 24 hours. So we've been sticking patients on pharmaceuticals that aren't ideal, do have some side effects. But again, if someone can't sleep at night and because they have burning and tingling, and it's affecting their sleep patterns, affecting their daily lives because they're tired. As we know, neuropathy is usually more apparent at nighttime. Medicine is always, risk reward, as we all know. So the reward of suppressing those symptoms, in my opinion, and many of our opinions, did outweigh the risk of sticking someone on gabapentin for a lifetime. For all those reasons, to reduce suffering, to improve sleep, those can have very negative effects on our patients. So it was okay to do so. I would say these days, it's in my being like an aggressive opinion would be at this point, it's a fairly poor standard of care. I don't think we should do that at all anymore, and I really try hard not to, and I don't very often anymore. And that's where this kind of talk comes to place, where you have to feel more comfortable diving into some new things out there to help your patients and not stick them on these drugs. And it's amazing how even when we get into the actual biologics, because there's a relatively reasonable cost to it, not terrible. The willingness for patients that I've experienced in the last several years is quite high, because this is a condition that is debilitating. And if it's not debilitating, at the very least, it's quite annoying, and it can become debilitating. So the interest level that I've seen the last few years with my patients is very high, and they don't mind spending a few dollars to actually attack the problem. So I think you find yourself becoming more and more informed about biologics. You'll get comfortable using them in your practice for your neuropathic patients, and hopefully the use case or the usage of those meds will go down. So historically, in recent years, there's been some ways to attack this condition beyond gabapentin and Lyrica. I'll go through a few that maybe some of you are doing out there. I've done some of these things, but just say, meh, not thrilled with my results. Laser therapy. Laser is a photobiomodulation. It's the absorption of light energy at a certain wavelength that has a beneficiary effect to the nerve cell or another tissue as well. And essentially, you're increasing the efficiency of mitochondria, maybe some more oxygen concentration, maybe some more nitric oxide. Pretty well proven that they'll reduce inflammation and help, quote unquote, repair. The problem that I saw with laser, and I didn't understand the physiology behind this years ago, because I didn't know as much as I know now. But again, back to the disintegration or the collapse of the epineurium, the cell wall. If there's nothing there or not much to work with, there's not much to repair. So I think that's why laser is very mediocre. I think laser is pretty impressive in some other parts of the anatomy, but with neuropraxia specifically, and it is a cartilage, just for a good kind of nugget to know, it is technically a cartilage-based defect. So as the cell wall falls apart, as the epineurium breaks down, that is technically a cartilage-based defect. So if you're missing part of the anatomy, it's hard to augment or repair what's missing. And I think that's why laser doesn't work very well. Other things that people have been using in recent history, I find as a supplement, vitamin B, specifically B12 and alpha-lipoic acid, are useful. If you catch someone real early and there's still enough structure and function to the nerve cell, I think you'll see some decent results. And I'm sure a lot of you have used it. And we can get into another time, IV drips of these things. And I think I look at them as a supplement or as an augmentation. If you catch someone very early, you might see some reversal of symptoms. So I've had decent results using alpha-lipoic acid and vitamin B12, and you got to use the natural version. A lot of vitamin B12 is synthetically made, and the bioavailability is not very good. So it's got to be naturally occurring B12 and alpha-lipoic acid. But again, I use that now more as a supplementation, if I even use it at all. But as a sole weapon, again, early cases, maybe you'll be slightly impressed. PRP. My biggest problem with PRP, and I have a practice pretty heavily weighted in sports medicine, and I really like treating those injuries. Before, again, I really took a deep dive into biologics. Just intuitively, I knew that by using PRPs, oftentimes, just by logic, couldn't make a whole lot of sense, because especially for neuropathy, because if we're talking about neuropathy, as we are tonight, how many patients do we see with neuropathy who are 25 or 30 or 35? Almost none. So most of our patients who are neuropathic, 40s at the earliest, 50s and 60s, and it just booms from like late 50s, 60s, 70s, of course. So at that point, what is a person, and that's why I barely did it for neuropathy. I would sometimes use PRP in my practice for arthritic conditions, but it's fairly age dependent, is my point. And because most people who are neuropathic are going to be 55, 60 plus, what am I really giving them back? That was my issue. So I didn't really do a whole lot of PRP for neuropathy because I knew it wouldn't work. And here and there when I did it, my results were not impressive. So laser, alpha-lipoic acid, vitamin B, PRP, not so great. As I looked into understanding this a little bit more, and I don't always do metrics or testing. I'm a big fan of kind of feeling out my patient. So if I notice I have one of the patients that wants to just get right to business, I won't always do this, but I often do epidermal nerve density fiber testing. And some of you may have done that. I'll tell you a little bit about it. And some do EMG still. But you also should kind of know what level of neuropathy you're dealing with. The good thing about neuropathy is when it's symptomatic, when the paresthesias are present, and the patients have all the annoying symptoms, generally speaking, they're somewhat early or moderately through the disease process. If they're completely numb, it's over. There's nothing to work with. When they're completely numb, if you would do, like, for example, an epidermal nerve density fiber test, they would see, they're looking at axons, looking for the axonal under the field of view in the microscope. And they're literally counting axons per, I think, millimeter of skin. So you do that punch biopsy, you put it in your solution, you send it to the lab that you like to use. And they literally are looking in the field of view and they're counting axons. And they're supposed to be X amount per, I believe, 1 millimeter or maybe 2 millimeters, I forget. If they're gone, there's nothing to restructure. But they're usually only gone when the patient's totally numb. Most people will get to us before they're totally numb because the aggravating symptoms of that I've mentioned before are what make people go to the doctor. So most of our patients we can work with, which is really cool. So as the cell wall falls apart, the epineurium falls apart, and the myelin has nothing to attach to, and therefore conduction doesn't work. So what else can you do? And that's where biologics come into place. When you use a biologic, whether locally or systemically, what you can do is you can provide the structure, you can provide the extracellular matrix, you can provide the growth factors, the collagen, to help rebuild the cell wall. So again, you need some cell wall to work with. If the epineurium is totally gone and completely collapsed and dehydrated from all the glucose and then the sorbitol uptake, well, you're not going to get a good result. But if you still have something to work with in the secondary response the body gets after application of these biologics, it's like if you got maybe like it's a spider. And I say this sometimes to my colleagues, if you got a beautiful spider web, it's in the corner of the room or outside on your porch. You throw a pebble at it, you bust it up a little bit, that spider can fix that. It won't take too much energy, won't take too much time, it's fixable. If you take a big old rock and you throw it at it or you knock it down with your broom, it's gone. The spider's gone, it's not going to remake the web. So in our patients that still have some level of epineurium that remains, it's not completely collapsed, there's some structure to work with. If you use a good biologic, in my opinion, that's allograft tissue. Allograft tissue has the most predictable amount of collagen. And that's what this needs. That's the cartilage-base defect that we're trying to work on. If you give it that supplementation and you have the secondary inherent response, collagentic differentiation response, you can help build back upon that kind of falling apart cell wall, and you can recreate the connections. As the connections recreate, you increase your myelin, which is really lining the axon, and then conduction returns. Paresthesias subside, and normal sensation reoccurs. And that's the whole key to why allograft Wharton's jelly-like biologics can really be a tremendous weapon for neuropathy. And in my experience, it just crushes everything else. So I've been using biologics, allograft, Wharton's jelly, probably over maybe 3 years now in my neuropathic patients, but more and more in recent years because you accumulate your own data. And I can read about all the studies in the world, they're very helpful. But for me, at least, and I think for a lot of docs, nothing beats your own experience. So when I have patients routinely coming back to see me who are so pleased with their results, I know I'm doing the right thing. So it feeds upon itself. I start doing them with not some hesitation, with like, okay, let's try something else. I've done the laser. I've put God knows how many people on B12 and alpha-lipoic acid. I've done some PRP. Very so-so results. Let's look into this stuff. and the results are awesome. And of the several different pathologies that I attack with Wharton's jelly, um, not only is this the most rewarding because it's such a stubborn, difficult to treat condition for so many years, um, forever in medicine, um, it might be the highest success rate I have, and I'm a fan of it for ligament pathology, I'm a fan of it for tendon pathology, to a decent degree, bone and joint pathology, but I would make the case that my success rates are actually the highest in neuropathy. Um, so it's just such a win-win for me and for my patient. And you can feel real comfortable going in this direction with your patients for neuropathy, and finally have something that really is going to give you and your patients the successful results you're looking for. So that's the bulk of what I want to chat about, and certainly can open up the floor to any questions.
Awesome. Thanks, Dr. Bell. Let me go into chat here. Marcus, do we have the Q&A section up or is it just chat?
There's a Q&A section. You just have to hit the More tab and then Q&A.
There we go. Okay. We'll start with our first one here. Is it possible to reverse the nerve damage of someone with mild neuropathy symptoms and have a negative EMG after treatment? If the person is completely numb in the toes, would you do treatment for that person, or would it, or would you say it's too late? If so, what other options would they have, at least to try to lessen their suffering? Which product do you use, Nano Flex or PRP Jelly?
Oh, lots to unfold there.
Oh, a
So
3-in-1.
that was 3-in-1. All right, so a lot of bang for the buck for this one. So it's just, I think, like anything in life, transparency is the key. So I don't too often see people that are completely numb, but we see it. So I'm just going to be honest with them. I'm going to tell them that the success rate is much less with complete sensory nerve deprivation. And I'll kind of explain to them your nerves are kind of gone. That's why you don't feel anything. It's not impossible. You may have some structure left of some of the sensory nerves, so it's not impossible. I would tell the patient, look, odds aren't very good in the case of complete numbness, but hey, if you're okay spending some money and you want to give it a whirl, the wonderful thing is there's everything we've studied and know, and what the data supports is there's no downside. There's no negative side effects. This is a safe, effective way to attack this condition. So I don't have a problem doing it. I'm sure I have. But it's if they're completely on that end of the spectrum, I'm just going to tell them that the odds are a bit low. As far as product, I think I look at product two different ways. I think if you work at a bigger institution, if you work in a big practice, if you work for a hospital system, well, if you work for a hospital system, well, maybe you're here and that's great. But I see this going to the big corporate, medical systems a little bit later, unfortunately, because the protocols tend to get kind of stuck. It's hard to move things along in a bigger system. But if you're in a smaller practice, what I recommend to my peers, if you're in a smaller practice, I think you have to be nimble in product selection. If you get, in my experience, if you get too stuck in protocols, and protocols are good, protocols are what data has shown us. Platinum's done a tremendous job in helping develop protocols as the amount of data they've collected and what we're going through here. The Institute of Regenerative Education has collected a tremendous amount of data, and we need data, so that's really good and important. And I like the protocols for sure. If you're in a smaller practice, there is a practicality that I think you have to utilize. And like I said, you have to be nimble on your feet. And in your success rate and having your patients wanting to go forward is sometimes it's just cost dependent. And I think for me, at least, for someone who is successful in having their patients wanting to do this, it's my authenticity, it's my passion. And it's really, and this is kind of a personality thing, and anyone can get there. I think for some people, it's even others, you got to be able to read your patient. If you get too protocol driven, you might spook some patients, and then you can almost see they're like adding stuff in their head. The great thing about Wharton's jelly in general is that, like I mentioned earlier, its efficacy is very impressive. You don't have to go to the highest end product. You don't have to hit them with 5 rounds. You don't have to necessarily go systemic application. Now, in certain protocols, yeah, in the best case scenario, I love doing protocol Wharton's jelly today, say by NanoFlex, a certain product with X amount of milligrams of MSCs, so mesenchymal stem cells, and then 8 weeks later, another round, and then maybe a systemic application. And we have those protocols for you guys, and they're great. And I think you need to be consistent if you're in a larger practice. You can't have one doctor in practice doing it one way and 3 others doing it another way and 2 others doing another way. That's probably jumbled. If you have a relatively small practice, I think if you're nimble and you can kind of read your patient, like for me, when I see somebody that's doing the math or getting a little spooked, I narrow it down and I start going right direction of it. And this is because it's true that sometimes 1, maybe 2 rounds of just local application, just injectables, does a great job. I don't need to nebulize them. I don't need to IV them. Would I love to IV or nebulize everybody? Absolutely. But quite frankly, I don't very often in my practice, just the way things kind of work out. And my results are excellent, as I mentioned. So I use product based on my feel for the patient. I feel they're apprehensive. Maybe I'll go one way, tone it down. I feel like they're real gung-ho. I might go a little bit more the other way. But at least I know whatever I do, and if it's kind of the bare bones, I'm more than likely to get a good result. And of course, the more I do, the results could increase. If I personally like epidermal nerve density fiber testing, so if I'm going to test them first, and I'd say I'm a big fan of, again, being nimble and feeling my patient out. If I get the kind of patients like, doc, let's get at it, get me better. I don't give a crap about you telling me the exact amount of neuropathy I have or doing it. Boom. Based on their subjective findings and the tuning fork, and they're diabetic, I can be pretty damn sure if they're neuropathic or not, if they have neuropraxia. Maybe that's a 20% of all people, 25%. It's a decent number. The rest do probably enjoy getting a definitive diagnosis. So again, I do epidermal nerve density fiber testing because I think it's a little bit more tailored to what we're doing versus an EMG. So if my epidermal nerve density testing comes back, and let's say it's mild neuropathy, and again, pathologist is counting the number of axons he or she can see in a field of view, then I'll probably go to nano DPM because the disease state isn't that progressed yet. I'm not talking about moderate or severe disease. I can go a little lower end. My costs are down, therefore my patient costs are down, and I don't have to make a whole production out of several rounds in systemic application. So when you get a metric, that's the benefit of it. You really know what you're dealing with. So my go-to, if we're talking about Platinum's product, is nano DPM, a localized application. If the disease is more severe, I might go to a product that has more milligrams of the MSCs. So that's how I choose product, the severity of the disease. And I usually dictate severity of disease by metrics given to me when I do the epidermal nerve density testing.
I think that's one of the counterbalancing acts of having to be in a cash practice is whether you like it or not. Cash businesses, there's a bit of selling and educating, and those sometimes can blur the lines in front of a doctor. And it's understanding how you do a bit of both without doing one or the other too much, right? And I think that so anyways, because there's another question, what dose of Wharton's jelly? Matthew, I think we kind of went through that, and we can do some more peer-to-peer, more direct answers on that. But I guess you could also say, Dr. Bell, even if you start bare bones, usually there's a significant response, even with the lowest end, that if they do need another 2 or 3 application to end up where they would have been with a more aggressive, expensive one, you can still arrive at the same point with the patient. It just may take longer. And sometimes building blocks of enthusiasm, can that be better for someone, especially if they are kind of shifting in the seat?
Nailed it. So that's exactly it. So I don't like to get terribly definitive. What I generally say, again, because this is what I've experienced, is that, hey, and this is like the exact line I use when we're talking about results. I'm like, the results are darn good. I've been very impressed the last couple of years. And I say to them, I almost answer the question for them. I say, listen, we'll do this. This is what I'm going to use, the product I'm going to use. And I'm going to reassess in about 6 to 8 weeks. And I say this for them, and they all end up agreeing and nodding. I say, if you come back in 6 weeks and you're thrilled, then you're done. You did great. 1 round, boom, we did the bare bones. But if you come back in 6 to 8 weeks and you're better, you're 30, 40% better, your symptoms are less intense, you'll be more than likely very open and excited to do round 2. So in 6 to 8 weeks, if you're 50% better, you can be pretty darn confident if we do round 2, you're going to get that much better. And just like you said, Bevan, especially with this kind of condition, it's a lifelong problem. It's a little different than like a tendon or ligament tear, a rotator cuff tear. It's not a lifelong problem, but for a lot of diabetics, they've had neuropathy for several years, if not longer. They're fed up, as everyone out there knows, as I'm saying this, they're fed up. So if there's any condition that people are going to spend some money on, it's this one. So absolutely to your point, when people come back, and that's why I leave it like open-ended. And I tell them, if you come back in 6 weeks and you're pleased, but it's not going, hey, I'll do another round if you like. If you don't, and you're happy for now being 50% better, great. Stick with 50% better. I'll warn them that, this is the kind of condition that if you don't really get at it, it might start to regress. And I'll say, if I can tell maybe it's a financial thing, I'll say, hey, listen, you're so pleased you're 50% better. You're going to hold off. You want to hold off round 2 just because it's a bit of a cost? No, of course, no problem. Let's hope you stay there for quite a long time. But I will tell them, if you start to regress, you don't have to call me the next day. But if you start to regress, don't wait 6 months. Call me and get back here before, again, we lose more structure. Because again, the biologics, they work, they need extracellular matrix. They need something to grab onto. The axons need something to hold. So we don't want to let it digress too far, because then the outcomes of round 2, I'll tell them this, it could almost be like starting over. You want to build upon what to the level you've improved. So whatever you got back, you start to regress, don't let it regress too far. And I see that a lot. I have a lot of patients, some, let's say 50% better. Let's use that as a hypothetical case. Most often they do round 2, for sure. Here and there, let's say for financial reasons, it's a little, everyone's budgets are different. No problem. I never make them feel uncomfortable, obviously. They'll come back. I'll give them that information, and they're not going to wait 6 months to come back if they begin to regress, because when it comes down to it, spending $1,000, $1,500, $2,000 to hold off a condition like neuropathy and not go back on their gabapentin, it's just such a no-brainer. And even people that have very limited budgets, they find a way.
Love it. So we've got anything about using Wharton's jelly with patients with a history of cancer. Do you have any protocol or anything you like to stick by in your office?
Yeah, I've evolved. I'll feed off Dr. Martin sometimes. A couple years ago, I would be like, no. And it's the same reason I think all of us who use this, who really are, have done our due diligence. There's no reason as to why this should augment or increase recurrence. What none of us want as providers is someone, let's say, who's in I'm sorry, remission. I don't mean recurrence. I'm sorry, I meant remission. Let's say someone's been in remission for whatever cancer for 2 years, and you use Wharton's jelly, and then 4 months later they have a recurrence. Some people are going to think it maybe was that, and there's really no reason, with all the studying that I've done, there's really no reason that would be the case. But it's a situation that you may not want to put yourself in, because people are looking for reasons sometimes. It's about the only one of the very, very few conditions where it's not an absolute anymore. So it was an absolute no, because I didn't want the headache. And I didn't want the patient to have the headache and then be frustrated with the second guess. I was like, why the hell did I do that mesenchymal stem cell for my whatever condition? I don't need people thinking like that. That's upsetting. As time has gone on, and again, it goes back to your own experience. And I've used these for several years now, and I use them a lot. For a few different conditions. So it's a big part of my practice. And I'm more and more confident and comfortable that there's no connection. What I do now, of course, I'll go over all this with the patient. I will say there's nothing we know at the current time that would be any indicator that this would increase odds of any kind of recurrent cancer. However, cancer is a funny thing, and we oftentimes don't know why it comes back, and it's its own pathology that I don't know. I don't treat, and I don't discuss too much. I don't go too deep there. But and if they trust your doc, and my patients trust me, if you have that good rapport, I generally get into now, I don't see any reason why it jeopardizes you, but I will put it on their consent form. So, and I tell them that. I say, listen, I'm going to add a paragraph to your consent form. I'm not trying to spook them. I'm just trying to let them know that, hey, cancer's a funny thing, and everyone hates it, and it's terrible, and it comes back for all these different reasons, and who knows why, and it's mostly, I don't even get into it. Like, there's a million reasons. And I tell them I'm comfortable, and if they're diseased, if they're, say, neuropathy in this case is that debilitating, they do it. And I just, again, transparency. I'm just going to add it to your consent form. And I have some that have plenty that have signed it. I almost find myself I'm the one, not talking out of it, but if they trust you and you know what you're talking about, they usually want to do it. If they can do it, great. Don't do it. They should not do it. If there's I tell them, if there's going to be any doubt in your head, I don't want you to do it. Now, if you really, really want to do it, then you should do it. But if I sense doubt with the patient, then I'll kind of walk them down that's not. If I sense pure enthusiasm, like I'm so sick of this neuropathy, I can't sleep, it's affecting my quality of life, it's a different story. And then as long as they're informed, we'll move along.
Thanks, Dr. Bell. And guys, there is no one should be doing anything without a proper consent form when it comes to biologics in general. And you can have an additional qualifier for that. And if it's that big of a deal and someone is worried, because states are different, state medical boards are different, how they view these things. Some people have state stem cell laws. They're really endorsing a lot of the experimental use these days, right? You don't need them to do it. But like Dr. Bell said, everyone's going to have their own version of it too. So, I mean, look, if they had an oncologist, you could even have the oncologist sign off on it, right? So, anyways, I would say to your comfort level. But obviously, I think anyone, the general rule of like, they need to be six months or 12 months, past it or whatever is a good rule of thumb. But I think it's personal as well. So, okay, I'm gonna blast through these three because they're kind of all the same. So, starting with the physical exam, what do you use for neuropathy patients? And then after you go through the physical exams you do, Dr. Bell, can you go through the actual treatment process and placement, such as distal to proximal or proximal to distal, and kind of just go over your protocol from, all right, I'm going to examine you this way, and then we're going to grab the Wharton jelly, and we're going to do this and this with it.
So a lot of this obviously is subjective findings. It's a pretty easy, relatively speaking, easy diagnosis for most of us. So again, we'll use the diabetic, but if they're presenting, they're saying they have tingling, burning, pins, needles, numbness. Already we're all thinking that. So the first thing I'll do in my physical exam, and it's rarely the case, but they're diabetic, so they often have vascular disease. The first thing I'm doing is I'm doing an arterial exam. And if I find or I suspect any arterial disease, I'm not worrying about the neuropathy at that visit. As we all know, that's more pressing. That's obviously something that can lead to catastrophic events. Who knows, a week or 2 weeks later. So first thing, vascular exam. If that comes back so, again, I work them up for arterial disease, and then I'll go back. There's no reason not to treat the neuropathy if they have vascular disease. But if it's a new patient, I'm gonna do my physical exam. I'm gonna attack that first. But let's say hypothetically they have palpable pulses, and I'm comfortable in that regard. Sometimes I use an audible Doppler, but I use my hands, real basic. And if I don't feel a pulse with my fingertips, then I'll use my Doppler. And then again, if I'm not impressed there, and I don't like the skin color, texture, turgor, the appearance of it looks a little pale, cyanotic. Again, work them up vascular. Then I get to my neuro exam. So what I do is I keep it really basic. Again, they're cueing us. The symptoms are pretty darn standard. The tingling, the paresthesias, the burning, the tingling, the pins and needles. I usually will ask them, do you feel it with any frequency more often at nighttime? More often than not, they'll say yes. That's classic neuropathy. I ask them what their hemoglobin A1C is. If it's 7.7, it doesn't take much. And by the way, and I tell this to the patients all the time, you can be because sometimes patients, I see them, are getting visibly upset. They have this condition, this disease that they kind of know they have. That's why they're there to see me. And it's a 63-year-old woman, and she's built nicely, and she's not overweight. So she's 130 pounds. Her hemoglobin A1C is 6.9, and she's like, how do I have neuropathy? I tell them this all the time, like, you're doing great. Your blood flow is great. I just checked your pulses. You look healthy. You're at a good weight. Your diabetes is not ravaging you at all, more than likely. Nerve tissue is very, very sensitive to elevated blood sugar. So even very well-controlled diabetics can develop neuropathy. So I go out of my way to tell them that. And it's true. So that's why I think this talk is so worthwhile. And that's why 3/4 of all diabetics will develop neuropathy. The nerve cell is, again, for the reason I mentioned before, the glucose to sorbitol, it breaks down the cell wall by dehydration, very readily. So I tell them you can be a well-controlled diabetic and still get neuropathy. So I put a lot into their subjective findings. They tell me they have symptoms more often at nighttime and more intense at night, and it's burning, tingling, pins, needles, and they have a hemoglobin A1C of 7.2. I'm like, all right, well, it sounds like they have neuropathy. I talked about it for that like a minute or two. And then I'll do some very simple tests in my office. I'll do a tuning fork. The sensation of vibration I feel is the first to go. If they feel that less than about 10 to 15 seconds, even more, and I explain to them the sensation of vibration is one of the first to go. So I touch them with the tuning fork on the dorsum of the foot, say. I actually just do it in my head. Some docs may take a cell phone and actually time it, but I just go, 1,000, 2,000. And if it's anything, less than 6, 8, 9 seconds, that's a very typical sign of neuropathy. Certainly if they don't feel vibration much at all, it fades in 2 or 3 seconds, which is common. And I explain to them your ability, and I'll often grab their hand and say, now tell me about your hand. And I'll hit the fork, touch their hand, and they're like, oh my God. Well, and I'm counting in my head kind of. And then if they finally say, okay, vibration stopped. I'm like, okay, that was roughly 20 seconds. Your foot was 4 seconds that you felt it. Your hand and foot should be relatively equal. The foot's the most susceptible neuropathy. This is classic neuropathy. So I may even stop there. Sometimes I'll use a Sens Weinstein and I'll do a light touch to the toes. I'll have them close their eyes and I'll say, tell me 1, 2, 3, 4, 5. I see your big toes number 1, your pinky toes number 5, everything between. Give me your best guess. Close your eyes. If they're always off, I'll check 3 or 4 toes. Takes 15 seconds. That's again a pretty typical sign. That's all I do in the office. Then I get right into treatments. I get into things that I think are going to help them. And I tell them, I start off kind of like the way I start off the lecture. I say, of course, I dull it down, but I say historically, myself and maybe any doctor you went to, whether it be your family doc, your podiatrist, your pain management specialist, they be put you on gabapentin or Lyrica. It's a mistake at this point because we have better options. So I don't like to do that. That will mask your symptoms for the life of the drug. It's not treating the problem whatsoever. And ultimately, it's really not that good for your kidney. What do we know about diabetes? We often have renal disease. So, and I get right into, there's a way that I'm most impressed with to help this condition. And my standard line is, hey, it's not covered by insurance, but it's not terribly expensive. It's safe, and I've been doing this for several years. This is a fair number. I've treated, I think we're at 250 patients now in my practice with just neuropathy. So I say I've treated over 200 patients with this condition the last couple of years. And I have very impressed results, and I just go from there. And I tell the patient, if you would like, I said at this point, I'm comfortable with moving forward with this if you'd like. If you want a more definitive diagnosis, boom, I get into, we historically do EMGs or nerve conduction studies, and that's when you probably have heard of them, or if you don't know what it's called, that's when they put like the little pins up down your leg and they send little shocks down your leg, and they're assessing the velocity of the conduction of your nerve. That to me is fine, but I say what I think is a little better, and I like to do is I do this epidermal nerve density testing. It's a real easy, quick test. Your insurance covers it. We do it right at the office. I can do it, next week. We'll get you back, and then we can get a definitive metric. Once that comes back, whether it's going to be mild, moderate, or severe disease, then I'll choose my product. I'm more of a needle guy with this as opposed to systemic, but I love the systemic application of using some exosomes and such. That's more for maybe peer-to-peers. I don't get too into that now, but I attack the nerve where the symptoms are. So if their symptoms are plantar, posterior tibial nerve. The symptoms are plantar and dorsal, and I hit the posterior tibial nerve, and then maybe I'll go across the anterior ankle to get the intermediate dorsal-cutaneous nerve. If the symptoms go up the leg and the dorsum, then I'll do posterior tibial nerve for plantar aspect, and then instead of across the ankle to the intermediate dorsal-cutaneous nerve, I'll go to the fibular head, and I'll get the perineal nerve. So I explain to my patients, and I tell them, hey, your symptoms, if it's just plantar aspect, I say, hey, Mr. Smith, you got lucky. Your symptoms are just the bottom of your foot. It's just one nerve. I think we can get away with just one application, for now. And I'll tell them, I said, if it was the top of your foot too, you got to me earlier. Usually the disease starts plantar, distal plantar, stock and glove distribution. So I'll tell them, hey, you got lucky. You only need one. If it's dorsum as well, then I'll just tell them, hey, I need to attack both nerves. This is what I like to order. I think one vial, it's cutting maybe a little short. So I really like to order 2. It's twice the cost. I tell them my price. It's not too terrible. Most say, let's go for it. Some will, if I can tell they're apprehensive, then I may say, hey, I can, if it's costing, I can always order one vial of, say, a Wharton's jelly, nano DPM, and I can split it in half. Go half to the tarsal tunnel to hit the posterior tibial nerve. The other half I'll do across the ankle, anterior ankle, hit the intermediate dorsal-cutaneous nerve. I say, it's that effective that we can maybe split it, but ideally I'd like to do one vial per nerve. So it's one of those 3 nerves pending where they're symptomatic.
Perfect. And do you use any guidance for that?
So I don't. It's certainly, obviously it's fine too. For me, I think it's kind of easy. I think optically probably looks good. They're spending money out of pocket. You can make a little more of a production. And for some docs, they just feel more comfortable, especially for the posterior tibial nerve. It's, it's deep in that tarsal tunnel. So I don't. I would say a chunk of docs do. Certainly personal preference. But it's the great thing about these and I say this often, you want to be close, but it's just so darn effective. I've been so impressed. You don't have to be like spot on pinpoint. You're going to get secondary collagenic differentiation. So, you know, you don't like have to like be 1 millimeter from the involved nerve. You'll be close and you're fine. I'd say if you have ultrasound, use it. Why not? If you don't, I probably wouldn't bother with the expense of getting it. Um, so that's my general feeling with ultrasound.
You know, they got those cool ones. I think they're like $3 grand now. You can hook them up to an iPad and let the patient hold the iPad and, like you
Totally.
said, make a bit of a production. So that's always, sometimes in the cash aspect of things, just because you don't need it doesn't mean sometimes it couldn't be effective if you're closing, right? And I know doctors don't like to hear that term, closing, sometimes, but it's just it's part of the reality you're living in a cash practice. Because look, if you're not going to do it, the insurance company's going to close the door in your face. They already have, just whether you've acknowledged it or not. How long is your typical treatment protocol? Meaning, I think we kind of gone over that a little bit, Dr. Bell, but I think I'm seeing some other similar ones. How long do you wait? And you said it's important to kind of maintain momentum if we can.
Yeah, it's
How
critical.
long do you like to space it between? And when do you see pickup or loss of momentum? Like, how do you feel
Sure.
that out?
So my wheelhouse is probably 6 weeks. If you do four, what I've seen is it may not really have kicked in a whole lot yet, and they're going to think it's it kind of maybe a little bit of a wasted visit. So I've again everything's experience, and as the years have gone by, so now my wheelhouse is about 6 weeks out. So at 6 weeks, I kind of feel like you got a good outcome for what you just did. You got a good feeling of what it's going to do for you. Not that it's necessarily peaked. What I tell patients is exactly those words. I say it didn't necessarily peak at this point, but you have a good general sense of what this, how far it's going to take you. So if they're, if we use a number, like I do a little survey sheet for my patient, I think they like it. And that's how I kind of keep some of my data besides my charting. And we do like a 1 to 10. And we use the words like, you know, I don't use pain because neuropathy is not really pain. It's more like uncomfortable and nuisance. So we use a 1 to 10 scale, 10 being extremely uncomfortable, one, barely uncomfortable, and so forth. So if they start at an 8 and they come back at a 4, they're stoked, they're happy, they're very excited. And I will tell them at 6 weeks, like, it doesn't mean you may not go to a 3 or 2, but you kind of probably got what you got. And that's where the momentum thing comes in. I'm like, if you're happy to be in here, hey, listen, there's no medical downside to going round 2. This stuff's safe. I love it. I've been using it for years. If you're at a 4 and we do round 2, you're probably going to be to a 1 or a 2 or maybe even a 0 another 6 weeks. So I'd recommend doing another one. That's really good momentum. More than half will they're so excited they're going to go for it. A certain percent may say, you know what, doc, it's a little pricey. Is it okay if I don't? I said, of course it's okay. Just I'll get back to what I said during my little speech there. Just if you notice regression, don't wait too long to come back. We want to build upon what we've gained. So I generally do 6. So I'll do 6 weeks, and then if I do a second round, I'll see him in 6 weeks again. Now, if I do a systemic application, I usually will just, again, I have a small practice. It's me and another, so I'm not in this big clinic. I have the ability to kind of pick and choose patient to patient. We don't have like strict protocols. Again, there's not 10 of us in the practice that kind of, why is one doc doing it one way, why another? So I have the luxury, and I kind of like it that way, of doing whatever the heck I want. So I'm a good, I like feeling people out, and I think that's just a good thing to do. I think people appreciate that if you're kind of on the same page as them without specifically discussing that. So if I'm going to do a systemic application, and they're going to do like the really go for it protocol, they're going to come back in 6 weeks, and no matter what, unless they feel that perfect, which happens, then they're going to do. In my practice, they're going to nebulize, and then again we go from there about 6 weeks. I'm a 6 weeks with this. 6 weeks, 6 weeks, 6 weeks.
Love it. Do you ever mix, we got a question. Do you mix B12 with Wharton's jelly? And then are you using ECS therapy in conjunction with the biologic?
Yeah. So I don't think it does much, but there's no harm. Honestly, it depends if I remember or not. I usually remember. I don't drip it. No, I think it's great. I'll do full service. Do an IV drip of NAD, B12, alpha-lipoic acid. It's great. It's healthy for you. I just don't. I just haven't for no other reason than maybe lazy. Maybe I should be doing it, but I'm pretty darn busy and I got a lot going on. So I haven't gone down that path. But if I was going to have, or I was going to advise someone who's doing like a neuropathy clinic solely or a neuropathy kind of practice, then you want to offer all the bells and whistles and you want to think about doing that stuff. Um, quite frankly, though, ultimately they're so darn effective. I don't really know you need to get into all that. So if I remember to say so, I'll have them take orally B12 and alpha-lipoic acid. And there's some manufacturers that have, there's plenty now that have them both.
Well, I think that there's some people on here too that maybe don't understand or appreciate the other side of your practices. You've definitely hacked some limbs off people, haven't you?
Uh,
Um,
Probably over 1,000.
So just ladies and gentlemen, Dr. Bell has cut over 1,000, toes, fingers, and things off, right? So he is seeing the other side of this thing too. So for some of you that specialize more on the front end of private practice, right? Dr. Bell uniquely sees the horrors on the back end of this. And I think that's important to point out because I know that I'm sure you got to go in there and almost numb it up mentally sometimes, having to just kind of take it from someone, right?
To this day, to all of you out there who may do this as well, I mean, I certainly it's not a problem, but I usually have my resident do the last bit of that case from the actual body part, whether it's a TMA or a BK. If I have a resident with me, I'll have them do the last part because that last moment, still 20 plus years into it, it's not pleasant. So yeah, so I'm super busy. My practice is like it's everything. So and if my results were just mediocre, I would be adding. My results are darn good, so and I'm so busy, so I've kind of stuck with luck applicate with the injectables, but systemic application, which is a whole, it's not a whole other talk because the concept is the same. I don't want to get too much into the exosomes tonight, but it's a nice combo for sure. And I'm happy to go further into that with anybody, person, doc to doc will be fine. So, but ultimately, I guess my
I think
point
we'll
would
do
be
a feedback questionnaire for your next talk since we're done with the chapters.
that'd be great.
Um, what I had a couple people ask, what biopsy company are you using? And they said you do a 2 and a 4 or 0 and a something. I don't know what that means, but
So I use
four points or 2 points. There we go. I found
yeah.
it.
So good question. I use Bako or Bako. I say Bako, Bako. It's a big lab. They're good. They're kind of almost particularly known for this. They're good pathology reports, good service. So Bako, impressive. I think it's a good lab. I use it. They send us. I believe they send us the kits. I don't know. My staff always wait in the room for me when I'm ready to do it. It's a 2 millimeter punch, couple cc's. I'll do dorsal lateral foot and like dorsal lateral upper ankle ish. So I do 2 points. Some do three. I think it's probably necessary. Again, I'll do a little bit on symptoms. If they're that symptomatic and it's that far proximal all the way to their knee, then I might do 3 points. I might do dorsum of the foot. I might do upper ankle, and I might do then proximal leg. But if my patient's symptoms are mostly distal, which is most people, if it's the foot and maybe a little up a little up the ankle, which is most patients. I would say most of my patients and most of all yours, distal half of the foot, very, very typical. Here and there, the whole foot, and then a little bit less frequently up a certain portion of the leg. So I think 2 points is fine, but nothing wrong with doing foot, upper ankle, upper leg. And you always do bilateral, even though it's generally a symmetrical disease. If you do it, you should do bilateral, and you get paid for it. It's actually good reimbursement too. So if you're getting testing done, you're getting a true metric, and you're getting paid for it actually pretty well. So.
Fantastic. Any experience with central neuropathy? Example, vestibular neuropathy?
I don't. It's a little out of my wheelhouse.
Awesome. And we got another one, just basic. What do you charge? I know that's a loaded question.
Listen, I'll give you I have no problem saying what I charge. So that's of course product dependent. So let's say I mostly will use a product called Nano DPM mostly, or next product that has that many more milligrams of MSCs is called Nano Flex. Most docs, I think the standard out there for in this realm, whatever company you're using, doesn't matter. Most docs do around 3x, sometimes 4, some do 5. It's kind of nice to, you have to, I guess, kind of know your patient population. And frankly, I think the biggest, most important underlying factor is you. It's you, the doc. If you feel if they sense from you, you're a little hesitant or reserved, or you feel awkward asking them for money, you're gonna need a lot of no's. They're gonna feed off that. It's a subconscious thing. I'm not a salesman, I'm a doctor, but I'm confident, not because I want to make the money. I'm confident because I know I know it works, and I know how to talk about it. And if you're confident you know how to talk about it, you're gonna get a hell of a lot of yeses. And for 900 bucks, 1200 bucks, 1500 bucks to treat a lifelong condition or a condition that's been around for the last 5 years of life, 3 years of their life that affects them every day, you should be able to move it, and you should be able to do a lot of it. It's different than an injury. I do a lot of this for other stuff, but not at the frequency, not at the yeses, because of what neuropathy is and how much it impacts people. They know it's not going away. And if you educate them, you tell them it's not healthy to live on gabapentin forever, and there's finally a way to approach it with good results, they're going to say yes.
Awesome. How, so we have another question here. Plantar-based issues, where are you putting it?
So again, you can tack. It's kind of like I stole this from Dr. Martin, I think, way back. It's kind of like watering a plant. You put your water in your topsoil, and the water trickles down to all the little branches. So you generally, if it's plantar aspect, you generally hit the posterior tibial nerve. Once in a while, if it's just the toes, and it doesn't even go, let's say it's toes, and it's just plantar aspect of the toes, and it doesn't even go to like the med heads. It's literally just the toes. Maybe I'll do like an interdigital application between Mets 1 and 2 and 3 and 4. I'll just kind of like split it up a little bit. I've done that here and there, but by and large, I just hit the posterior tibial nerve if the symptoms are anywhere in the plantar aspect.
Awesome. Now I know we have a couple more questions, but they're a little bit repeaty and everything. And some of the other questions are a little bit, what they are is I'm going to defer them that these are great questions to ask on a peer-to-peer. And I want to bring that up, everyone. Couple things to bring up is, look, if you want to go through the protocols, if you want to see some of the recorded videos, we also have someone that said, can you go over the products? There's actually already a video on that stuff. We invite you all to join the iore.com. There's protocols, videos, recordings, and you can also book a peer-to-peer conversation directly with Dr. Bell and ask any questions you'd like. So you'll see a booking in the chat go up. That's the link. That's Dr. Bell's calendar. He's very gracious with his time. He's a very open book. You're going to get an honest answer. People really appreciate that about Dr. Bell. So if you'd like to take advantage of that peer-to-peer, there it is. What we'll do is we'll go ahead and conclude it because we're right on the hour. And the rest of these questions, really, I think it would really benefit from a peer-to-peer on those. I guess the last one. What, if any, pain meds or is there any meds that you should be aware about, Dr. Bell? Because I think this is actually a good question. Is that diabetics and people with neuropathy can kind of come in with a laundry list of medications. How do you want to go through how you handle that and like what goes through your mind and how you process that aspect?
Sure. So it's absolutely correct. You're mostly dealing with somewhat sick people and sometimes very sick people. So far, I haven't really seen anything that concerns me at all. There are certain meds that may, like I like to. This is not really diabetic. I like to stay away from NSAIDs and steroids. I think you may see some inhibition there of what the MSCs can do. As far as any meds they're on, everything that I know that I've researched on that I've experienced, there's really no contraindication other than I'll go back to cancer patients. So active cancer patients, I just usually wouldn't treat them because I don't know enough about chemotherapeutic agents. I don't know enough about immunotherapy to get into that. And so that's the only area where my experience lacks. So outside of that, no. And knock on wood, which I'm doing, superstitious. I've treated, like I said, a couple hundred patients. I think around 250 with neuropathy, and I'll leave it at we've done just fine, and there hasn't been any issue.
Awesome. All right, everybody. Well, check out the iore.com, and we'll give you guys the next notice of Dr. Bell's next talk. We'll put it up on the website and everything. For the meantime, the peer-to-peer, iore.com. Everybody, thank you so much. And you guys give a round of applause for Dr. Bell. Thank you, man. You're an inspiration to a lot of doctors out there. We appreciate what you do, and I'm sure I know the patients absolutely appreciate what you do. And it's a unique perspective to kind of see both ends of the spectrum, and we're glad that you could share that with us tonight.
My pleasure. Absolutely.
Awesome. Thanks, everybody. Have a wonderful night. Bye bye.
Bye bye.